Mother to child transmission of HIV, which is also known as vertical transmission, accounts for the vast majority of infections in children, and Nigeria currently accounts for about 14% of the global burden. Hello and welcome to another episode of The Last Mile with NACA. I am Adesu Walsui. Can mother-to-child transmission of HIV be prevented? Of course, yes, and you'll get to learn how if you keep watching.
Though the main mode of HIV transmission is through unprotected sexual intercourse, a significant number of vertical transmission cases also occurs from mother to child. Mother-to-child transmission, MTCT, is by far the largest source of HIV infection in children under the age of 15. This problem is significant in sub-Saharan African countries, where more than 80% of children living with HIV are found. MTCT may occur during pregnancy, labor, delivery, or after the child's birth during breastfeeding.
This is something that is absolutely preventable because the transmissions are vertical. It's coming from an infected mother, an infected child. So that cycle can be broken. Either that the mother doesn't have it, or the mother has the infection and they'll find some way to prevent it from getting to the baby. Once it doesn't get to the child, then of course you are both preventing the child from having the infection as well as reducing the prevalence of the disease at a national and even global scale. So the next concept is prevention, the prevention. So we call it PMTCT, which is prevention of mother to child transmission of HIV.
Indeed, if you look at both PMTCT treatment and HTS, Nigeria hasn't done very well when you compare us, bring us to the global stage. But if you look at where we're coming from, we've done a lot. Nigeria, as I'm talking, still contributes about 14% of mother-to-child transmission globally. We're not up to 14% of the global population, but are contributing 40%. So we're contributing more than our fair share of the burden of mother-to-child transmission. Like you know, NACA coordinates the national response. And what that means is because we're not an implementing agency, we work closely with all the relevant partners. So the experience will be to say that we have improved on PMTCT, okay, but we still have a long way to go.
In the absence of preventive intervention, the likelihood of mother-to-child transmission is quite high.
For transmission during breastfeeding and during pregnancy has the highest risk of transmission. If nothing is done, 100 women are HIV positive, they are pregnant, there is 25 to 40% chance. About 25 to 40% of them will transmit the virus to their infants. But if everything it is done, that risk reduces dramatically to less than 1%. So it makes PMTCT so important to controlling the disease in the pediatric population, shutting down on increasing incidence, reducing the prevalence, and of course, when you do that, of course, you contribute to a reduction in national prevalence values.
When does prevention of mother-to-child transmission, PMTCT, begin, and what does this entail?
This starts even before the mother becomes pregnant. Talking about the basic rubrics of HIV prevention in women of childbearing age, beginning from health education, health promotion, right from secondary school, as the women are leaving school, preparation to marriage and childbearing and pregnancy. So all the things that we know to prevent HIV. But once the woman is already infected, of course, treatment becomes a form of prevention, because the woman who is positive is being treated, is taking the antiretroviral drugs, the immunity is better, the viral load is lower, and we do know that with lower viral loads or well-suppressed viral loads, the risk of transmission is reduced.
I already told them that this is my status, that I'm living with the virus, that is the HIV virus. I was asked to do viral load tests when I talked to my doctor that I am ready to conceive. And when I carried out the viral load test and the result came out, and I was told that I have less than 200 copies, that I need to wait for some time so that I can become undetectable. But despite that the viral load was low below 200, that I can still take in. But I was insisting that I would like my viral load to be undetectable before taking in. They said okay. So I waited, did the second test again, and the result came out undetectable. So I went ahead to take in, and taking in, I was also placed on ARV treatment.
The National Agency for the Control of AIDS, NACA, through its implementing partners, carries out interventions to prevent vertical transmission of HIV.
We do a lot of community outreaches and strategies to reach them. All right. There are quite a number of them. One, beyond what is done in the facility for the woman who is able to come, or anybody in fact who is infected and discovered in the facility to have HIV. We do index testing, so you follow that person to sex partners. So if it's a man, of course you want to see the wife, and they want to see the family members because chances are that if a woman is infected, the child actually may also be infected, especially if that child is not taking antiretroviral drugs to prevent mother-to-child transmission. And the other program that have what they call some communities, they call them volunteers within the communities, they're also able to either mobilize the woman to a place she will be tested or actually test that woman in the community. All right. We also have strategy where we engage with traditional birth attendants to mobilize those women so that they can be tested. Because in some of the states of the Federation, you can even have up to 15, 20 or more women not even coming to the facilities at all. So they don't even come for ANC, and you need to test them. If you don't identify those women, even if you do 100% in the facility, there will still be a lot of gap in our PMTCT. So for such women, we'll go to the communities to identify them.
There are many challenges facing PMTCT, but the most obvious are financial and technical.
Yeah, there are challenges at different levels regarding prevention of mother-to-child transmission. The first level of challenge, you say, is non-identification. Cases that are not identified. But once they are identified, then the next level of challenge becomes important, and that is placing such people on treatment, linkage to treatment. Some of the terrains that the programs get to, sometimes we go to do some work in one way or the other, very difficult terrains where the program cannot get to, and it's difficult for the people to come out. Sustained care is there, and of course, you know that requires commitment at different levels.
You know, we in African, we believe in two things: religion and culture. So with this, they'll say, God forbid, I will never go for the HIV. It's not my portion. Holy Ghost fire, back to sender. And based on the approach, our healthcare provider are very funny. Based on the approach, I could remember vividly, without even discussing, going for the first time to register for antenatal, the person giving a head talk, standing there, saying, you better do your test though. If you get HIV, you're on your own. So if I'm in that shoe, I won't even dare go for it, because I believe that once I tested positive, this hospital might push me one side.
It appears a number of states still see HIV as something that should be handled by the donor agencies. So what we're worried, especially here from this part at NACA level, is if the donors, because we're already having signs of donor fatigue, if the donors were to withdraw, what will happen? The strength of any economy is the human capital. So a healthy society means you have healthy and strong economy. So it's an investment. If a child is infected with HIV because we're not able to identify the mother or put the mother on treatment and that child comes positive, if that child were to live 10, 15, 20, 30 years depending, as long as cure has not come, that child will be living on antiretroviral drugs for the rest of his life. And conservative estimate might be over 50,000, maybe 60,000, maybe more. But if we're able to come out now, make investment early, and then you're able to say if there are 100 women, over 95% of them cannot transmit it to their children. So you have most of those children not living the virus and requiring that treatment for a long period of time. You see, we've saved a lot of money.
Mother-to-child transmission of HIV can be eliminated, but it starts with knowing our HIV status.
We advise, strongly advise, not just pregnant women, that all persons know their HIV status. And knowing HIV status is not a one-off thing. It's not something you say, I did my HIV test 10 years ago. Especially if they are at risk, they are ongoing risk, then you should do the HIV. So that is the starting point. So once a person is positive or is negative, then the line of action becomes clear as to what next to do.
After 2, 3, 4 months, I went again for scan and I discovered that I was carrying twin. And at the end of the day, my viral load still was undetectable till I put to bed. And immediately I put to bed, they look for those nevirapine to give my baby for 6 weeks. And after the 6 weeks, I carried them out for test again. We call it DBS, that is dry blood sample. So they carried out the tests, and the result came out in a month's time, and I was told that they are negative.
So future is bright. The prevalence has dropped. And then as we keep putting more people on treatment, especially with the strategy of surge, working through people infected, getting their sex partners, getting family members, there are people who can be exposed, and then identify them and putting them in treatment, pushing them right into the communities and identify them. If we're able to do that and consistently, we'll identify, and maybe we can even get up to our 90-95% coverage for treatment. However, funding might be a challenge, so we want the government at all levels not to relinquish on their effort. Let them, if I bring more resources and take leadership, and with that we should be able to really contain HIV.
Women should get tested for HIV before and during each pregnancy. Greater involvement of male partners is also key in the elimination of pediatric HIV and the promotion of women's and family health.
They go like this now. Take am easy now.
Now hospital I dey go to do HIV test.
Now everything you dey do HIV test. Before you carry belle, you do HIV test. Now you dey rush go do another HIV test. Wetin you dey find, you go see am o.
No be so, my sister. HIV test no be bad thing. Now make I know my status so that no matter the result, my pikin no go get HIV.
HIV fit pass from mama to pikin.
Yes, so during pregnancy or labor, or even when we dey breastfeed the pikin. Yes, and my husband dey road dey come sef, he go meet me for hospital. We go do the test together.
Hey, your husband na man he be. But wait oh, una no dey fear. What if the result come out positive?
Fear wetin na? HIV no be death sentence. And medicine don dey to take manage am. See, nowadays people wey get HIV, they live their life normal like everybody else.
You sure say I no go follow you go do my own so?
Wetin you dey wait for now? Come make we go jare. With quick action, we fit stop this HIV waka from mama to pikin. Go do your own HIV test today.
The update segment is next. Don't go away.
The National Agency for the Control of AIDS, NACA, and the Institute for Global Public Health, University of Manitoba, recently held a press conference on the formal presentation of the evaluation report of the needle and syringe pilot program implemented by the Society for Family Health in Abia, Gombe, and Oyo states. People who inject drugs, PWID, and their partners contribute about 9% of new HIV infections in the country annually. Unsafe injection practices such as sharing contaminated needles are major risk factors for transmission of blood-borne infections such as hepatitis B, hepatitis C, and HIV. In his welcome address, the Director General, NACA, Dr. Aliyu Gambo, stated that achieving HIV and AIDS epidemic control among key populations such as people who inject drugs is critical in the push for the last mile in ending HIV and AIDS in Nigeria.
As we all know, people who inject drug constitute a significant chunk of people living with HIV/AIDS, and not only a chunk of people living with HIV/AIDS, people living and spreading HIV. And one way they spread HIV is via injection drug use. As we roll out activities all over the country, pushing for the last mile of HIV epidemic control, we see this population group as critical. And we see this an important tap that has been running over the last several years that has to stop for us to control HIV spread in the country.
Goodwill remarks were delivered by various stakeholders and partners, including the country representative of the University of Manitoba, Dr. Green Kalada.
University of Manitoba Institute for Global Public Health being a key partner to the government of Nigeria in areas of research, technical assistance, capacity development, and very importantly, contributing to global knowledge, generating it, analyzing it, sharing it globally, and contributing to global efforts in turning off the tap for the epidemic. To work with you beyond this, in other areas of research, in other areas of technical assistance, to ensure that we continue to contribute the richness of Nigeria program to the globe.
Coordinator of the National AIDS and STI Control Program, Federal Ministry of Health, Dr. Akudo Ikpeazu.
Many years ago, when the issue of harm reduction started, it was a very difficult conversation, and many of us around this room would acknowledge it was a very difficult conversation. So today is really, for me, a landmark. It shows that we've come very far from the period of initial resistance to acceptance to acknowledging that there is an issue and then there is a different way from the way that we had done it before. So these results that are to be shared today would be very important and interesting for us.
And Managing Director, Society for Family Health, SFH, Dr. Omokudu Idogo.
Through this process, we're able to engage up to 2,700 people who inject drug and build a very rich body of knowledge and evidence around what needs to be done as a response to actually roll back transmission of HIV within this group. So for us as an organization, it's been a truly satisfying experience. We remain very available to support in every way we can the national response, even as we move to scale up.
A presentation of an overview of the report was made by the Director, Research, Monitoring and Evaluation, NACA, Dr. Greg Ashefor, and the country representative, University of Manitoba, Dr. Green Kalada. The aim of the needle and syringe pilot project is to examine the feasibility, effectiveness and quality of a needle and syringe program among PWID in Nigeria towards scale-up of intervention and establishment of the monitoring and evaluation structure for PWID in the country.
Much work has been done in the fight against HIV/AIDS in Nigeria. However, more work needs to be done. Together, we can end AIDS by the year 2030, even amidst coronavirus pandemic.
Educate yourself. This is crucial in the fight against HIV and AIDS.
Get tested. The only way to know for certain your status and stop the spread.
Get involved. People with HIV and AIDS need care and support.
Say no to stigma. Stigma prevents people from getting tested and those living with HIV from treatment.
Spread the word. The more we educate others about the disease, the better we can fight it.
Adhere to COVID-19 prevention protocols, wear a face mask, and maintain physical distance in public places.
Remember, only united can we defeat HIV to finish and end AIDS by the year 2030. Get tested today. Let's fight HIV to finish in Nigeria.
This HIV test kit na ogbonge test kit wey WHO, Federal Ministry of Health and NACA don confirm. If you go like know more about the test kit, make you call NACA Information Center on top 6222 free of charge. Make you no eat, drink or use anything where they take clean mouth 30 minutes before the test. Or yeah, make you look for somewhere where be say na only you go dey there, we get better light and flat top. When you open the test kit, you go see paper where explain how you go take do the test. Read am well low so that you go fit understand them. You go still see test stand and another package where be say it gets test device, plus including test tube and something where be say them put am so that the package no go spoil. But you no go need that one for the test. Or yeah, open the tube, then put am on top the test stand. Now make you carry the test device, but make sure say you no touch the flat side. Or yeah, open your mouth, then rub the flat side of the test device one time on top your gum wey dey up and one time for the gum wey dey down. Now quick make you put the device inside the tube. Leave am there for 20 minutes before you read the result. Make you no read the result after 40 minutes. Now if one line show on top letter C and letter T, then the test na positive and you go need to contact NACA for advice on wetin to do next. If only one line show on top letter C, then the test na negative. The test no follow at all if no line show or only one line show on top letter T or the background will be white before can change to red. You go need to do the test again. When you finish, pack everything where you take do the test, put for inside dustbin. Make we support NACA to fight HIV. Know your HIV status today.
Are you pregnant? Get tested for HIV as early as possible to reduce the risk of NTCT, as well as protect your own health. Thanks for watching, and as always, please continue to support the HIV response. Do not stigmatize or discriminate people living with HIV. Avoid and discriminate sex. And lastly, know your status and take action. Till next week on The Last Mile with NACA, I'm Adesu Elsie. Goodbye.